Hello. Our guest today is NYU professor Sherry Glied. Welcome, Sherry.
Thanks, Bruce.
Sherry, we've known each other for over 20 years. Our connection began when you were the head of the Health Policy Management Department at the Columbia University School of Public Health. We continued to be in touch when you were the Assistant Secretary for Planning and Evaluation in Washington for the U.S. Department of Health and Human Services. And it continued throughout over the decade when you were the Dean of the NYU School of Public Service. It's been great to know you all those years.
It's been wonderful.
I was the director of a significant health policy research center called the Smoker Center at Brookings Institute, and Sherry was a major part of our international advisory committee. So Sherry, I want to begin by asking you, what was it like to be an international advisor to a health policy research center based in Israel?
It's been one of the most interesting experiences I've had, actually. The Smoker Center has a really unusual role in that it both does its own research, but it is very much responsive to the concerns of the Israeli ministry. It's really intertwined with trying to improve the quality of the Israeli healthcare system in a way that I think is very different from sort of completely independent and sitting off to the side foundation, and yet is also quite different from being within government because it's actually independent in its research work. So the structure of it has been fascinating. It's also been really interesting because I used to laugh that I feel like I had more ability to speak directly to senior officials in the Israeli health system than I often did in the U.S. health system, even though I've played important roles in that system. But Israel's a much smaller country. Smoker was very well integrated, and I've had fascinating conversations with people over time about how, in fact, the sausage is made within Israel, as we say.
Now, every year or so, I would bring to New York or to D.C. the heads of the health ministry and the senior people for the finance ministry, and the head of the health ministry would always say to me, make sure you give me an hour private with Sherry. I want to talk about my latest issue and get her input. So what was it like to be on the receiving end of a request like that from a country that, it wasn't your bread and butter? You were solving the U.S.'s issues. What was it like to get that kind of request?
It's also, it was of course extremely flattering. I should start with that, and also gratifying to be able to be helpful. I think one of the challenges in Israel is that it's a small country, and although there are really excellent health economists there and health policy researchers, there are not that many of them because there just aren't that many people in Israel. And I think that the minister appreciated hearing from somebody from the broader community of people who do this kind of work. And many of the issues that actually confronted the minister, or usually it was the deputy minister. The ministers don't really know anything in Israel. Shh, you didn't hear me say that. The deputy ministers are the ones who actually are the knowledgeable, the civil servants, the knowledgeable people within the ministry. They are usually variants on really fundamental economics problems that affect all healthcare systems. They're not uniquely Israeli. And in many ways, Israel actually copes with most of them very well. So I was able to talk a little bit about how developments in American healthcare economics and healthcare policy might be helpful within the ministry in responding to challenges that they faced.
Terrific. Maybe could you share with us maybe thoughts about some areas where the Israeli healthcare system is particularly strong?
It's useful to start at the beginning or nearly the beginning and to think about the development of the Israeli healthcare system from its origins. Of course, when settlers moved to Israel, when moshavs opened, they needed to have healthcare services, and they opened clinics and had physicians and so on. And then when they actually tried to develop a healthcare system, it was actually based on the German healthcare model, which is the Bismarck model of a healthcare system, which is a model with competing health insurance plans, or with health insurance plans. They didn't start by competing. Eventually, they came to be competing. And by the mid-1990s, Israel had codified a system with competing healthcare plans. There were 4 competing healthcare plans like HMOs. Everybody belongs to them. They're fully tax financed or almost fully tax financed. They provide healthcare. Now, it's a modified Bismarck model. I think there are several of them in the world. But what I think has been, for me, really interesting about Israel is that it's been able to adapt its healthcare system and respond to changes in the population, in the economy over a period of time that has seen tumultuous change in Israel. So it starts off as this system on moshavs, providing care to farmers in little clinics. And it remains a really robust system in startup nation with, tech bros and entrepreneurs and all of that. And so the way that system has adapted is, I think, really uniquely interesting. One of the aspects that's fascinating is that the Israeli government has been able to keep very, very strong fiscal control over the system, while people are largely satisfied with the overall quality of healthcare that they receive. And I thought I'd talk about a couple of features of the system that I think my Israeli colleagues are often a little uncomfortable about, maybe see as bugs, but I think of as features of the Israeli healthcare system. So as I said, the Israeli government is really assiduous in controlling the cost of the system. Each year they develop a basic basket of services that the HMOs have to cover. Those are covered mostly without cost sharing, without premiums. Everybody gets them. It's extremely egalitarian. There is this basic benefit package that everyone is entitled to. That's a model that economists have really always liked, this idea that there's a basic universal benefit package that everybody gets. The Israeli government is particularly good at using technology assessment and other tools to figure out what belongs in that basket. It's a richly defined basket that actually explains what the Kupot do. But and that basket, with those expenses, they account for maybe 62% of Israeli healthcare spending, which is a really low share by OECD standards, and allows the government share of healthcare to be pretty stable and fairly low over a long period of time. Now, of course, the country has become wealthier. Some people want more. People are very risk averse. And so the Kupot are also permitted to sell supplementary health insurance. They're allowed to sell a second layer of health insurance that allows people some additional benefits beyond that basic package. And I want to really emphasize that the basic package is a very good package. It's a very standard good package, but some people want more. Many people want more. So they buy extra health insurance through their Kupot, through supplemental health insurance. And that's a quite regulated market. It has a really interesting feature. Now I'm going to speak like a true economist geek here. But the Kupot sell the supplemental coverage. That means that if the supplemental coverage induces people to use more services, which it often does, that's a problem that many countries have, that if people have private health insurance on top of the public health insurance, they use more of the public service. But in this case, they use more of the service that they're already paying for from the same Kupot. So that actually solves this problem. It's called a moral hazard problem that happens in many systems where you have supplemental health insurance over a public system. That's cool. The second problem that it solves is that health insurance companies in a system of competing plans, they want to attract the most healthy people. Typically, they want the healthiest people. This is a problem called adverse selection. They want to go get the young, healthy folks. They don't want the older people to join their plans. But the supplemental coverage kind of stands that on its head because you really want people who buy supplemental coverage. That's a more profitable line of business than the basic benefit package. So the Kupot face two conflicting challenges. On the one hand, to try and get people who really never want to use any services at all, because that makes them do well on the basic plan, but also to attract people who might want more services by providing richer supplemental benefits. So that has actually allowed the Israeli system to have much less selection problem than many competing systems have had. So that, I think, is an interesting feature.
Maybe one more feature.
Well, I think another thing that's really cool about that is that the Israeli government, the ministry, has been able to use this supplemental insurance and the existence of the plans to actually market other products. And the most important one, I think, is long-term care insurance. So Israel is really unusual in having a very large private long-term care insurance market. That's something many, many countries have tried to do and have failed. But because in Israel they're tied up with the Kupot, they've actually managed to get a very large fraction of the country to buy private long-term care insurance. And that's going to be really important as populations age around the world and there's a lot of fiscal strain on the health system. So let me stop there.
Sherry, it's been great spending these 15 minutes with you, and even more so spending on and off over the past 20 years, spending time with you and learning with you and from you. So thank you very much.
Well, thank you for giving me the opportunity.